Good afternoon, everyone, and thank you to the organizers for this opportunity to talk about getting LDL cholesterol to target. As was said in the introductory comments, there's still a lot of discussion on whether we should think about LDL cholesterol or HDL cholesterol, triglycerides, or some of the other remnant particles. So hopefully we'll have a good discussion today. I have some funding from the National Institutes of Health, and I also get funding from Dalio Philanthropies and from Lippincott for book royalties. A lot of my work right now is based in hospital internal medicine, and in that I take care of patients who are admitted to the hospital for medical reasons, but not for any surgery. But I also spend a lot of time on research. So the research is mostly on cardiovascular research, focusing on diabetes and premature heart disease, and health disparities research, thinking about region and rurality. I also serve in advisory roles within our county, the Olmsted County, as well as with the State Department of Health on their Rural Health Advisory Committee and their Human Services Advisory Committee. So today I would like to share where the literature and where our current thinking is with respect to LDL cholesterol and cardiovascular risk. I also want to talk about a few clinical trials related to cardiovascular risk and discuss some of the guidelines for management of LDL cholesterol. And we'll talk a little bit about lifestyle interventions, and then I'll focus a little more on some of the pharmacologic interventions, including some recent clinical trials. Everyone here knows how LDL cholesterol has been discussed in the literature with respect to cardiovascular risk. If we take all of us are somewhere on this spectrum, so either we don't have atherosclerosis or we have some level of plaque or may have had an ASCVD event, which is atherosclerotic cardiovascular disease event, and then you have secondary prevention. And a lot of this is related to having a healthy lifestyle. And as the healthy lifestyle changes and becomes less healthy, then you start to have more of a role for LDL cholesterol, maybe plaque progression over time, and then you have a plaque as well as clotting and thrombus and other contributors. And if we talk about this, there are also many ways in which we can reduce ASCVD risk. And some of this can come from lifestyle. Some of it can come from pharmacologic intervention, so it could be statins. And then more recently, there have also been a number of non-statin medications that have come up in the literature. So I think most people would agree that LDL cholesterol has a major role to play in ASCVD primary and secondary prevention. There are lifestyle and pharmacologic strategies for risk reduction. And we mostly have statin and non-statin therapies. There's a lot more literature on statin therapies, and then now there's emerging literature on non-statin therapies. But before we look at that, let's see how big a problem LDL cholesterol is globally. This is taken from the Global Burden of Disease study, and these are data from 2022, so not that old, maybe about 2 years ago. And this is looking at the global map and where we have CVD mortality that has been linked or attributed to LDL cholesterol. And you can see that the map has different colors, so all the way ranging from, you probably cannot see the number very well, but it's less than 19.57 all the way to greater than 111.23. So those are the number of deaths that are attributed to LDL cholesterol. And there's a big range if you look at this globally. In high-income Asia-Pacific countries, it's the lowest with 73.6, and then it goes to 432.3 deaths attributed to LDL cholesterol. If we now look at the disability adjusted life years, and this is a way of understanding how much disability a person might have because of a particular risk factor, and then you can look at this over time. So that's what the disability adjusted life years are. And if we look at that related to LDL cholesterol, we see that it doesn't matter which part of the world you look at, whether it's Central Asia and you can look at any other region of the world, you have a high risk in females, which are shown in orange, and in males, which are shown in blue. In most parts of the world, it seems that the DALYs attributed for men is almost slightly higher. In some cases, it may be very similar to that in women, but for the most part, it also appears to be slightly higher in men. But the thing that's notable is that this is not a problem that is only for certain regions of the world. This is affecting all world regions. And the LDL cholesterol that's associated with higher DALYs, which are the disability adjusted life years, appears to be slightly higher in men compared to women. So the question is, that's fine if we try to reduce LDL cholesterol, but what kind of gain can we expect, or what kind of reduction can we get in vascular events? And this is from a well-known study that was published almost 15 years ago. And they looked at 26 clinical trials. So they took the data from 26 clinical trials. It had about 170,000 people. And they looked at all the effects that was seen in each of the studies. And what they saw is that the reduction in LDL cholesterol per 1 millimole per liter was associated with nearly a 20% reduction in vascular risk. And so from that, they looked at different categories. So they looked at people who had a concentration of less than 2 millimoles per liter, 2 to 2.5, 2.5 to 3. In all the ranges, they saw that there was a benefit of using statins to reduce vascular events. And so from this, they said that if we can reduce LDL cholesterol by 1 millimole per liter, we can get maybe about a 20% reduction in vascular events. Maybe if we go much lower, if we increase LDL cholesterol more, we might be able to get a 40 to 50% lower risk. And over the last several years, LDL cholesterol reduction has been a major focus of managing cardiovascular risk. The question is, do we try to reduce LDL cholesterol in everyone, or is there any way for us to predict who is at higher risk? So this was the ASCVD risk prediction score that was published several years ago. And in this was known as the pooled cohort equations. And they looked at a number of factors. So they looked at current age, they looked at sex, race, blood pressure, total cholesterol, HDL, LDL cholesterol. And then if the person had diabetes, was a smoker, and on medications for hypertension and cholesterol, and also on an aspirin. And based on this, you could predict this is free, you can go to their website and enter your profile, and it'll give you your 10-year risk of having an ASCVD event. And based on that, people were then put in different categories. So the first one is if your LDL cholesterol was greater than 190, they said, we don't have to try and risk stratify you anymore. We don't need to predict your risk. You're already at high risk, and we need to start talking about therapy. And then they had different categories. If you have diabetes and you're of a certain age group, then they would recommend starting you on a statin. But there are a lot of people who didn't fit in any of those categories. So here they wanted to then go on and look at people who were of certain age, so 0 to 19. Then they had 20 to 39 and 40 to 75. Most of the studies were based on people in the age of 40 to 75, so they developed that a little more. So if your risk based on that risk calculator was less than 5%, then they would put you in the low risk. So that means you have a low risk of having an event in 10 years. Or you might have borderline risk, intermediate risk, or high risk. So based on each of these, they would either recommend no statin therapy or no pharmacotherapy. They would say, particularly if you're low risk, they would say, continue all the lifestyle that you have right now, focus on lifestyle to keep your risk low. As you start moving towards borderline risk, intermediate risk, and high risk, then it starts to become a combination of pharmacologic therapy as well as lifestyle therapy. They also wanted to look at a number of other factors like risk enhancers. Do you have a family history of early heart disease? So for some people, that would be if they have a father or sibling who's had a heart attack under the age of 55, or a female member who's had a heart attack under the age of 65, or looking at some of the other risk factors. So that's how they try to take a combination of your current profile, family history, risk enhancers, and to decide if you should be on therapy or not. So the PCE estimation, it was based on certain cohorts, it was based on certain races, and it didn't apply to everyone. So more recently, the American Heart Association came out with a new score, and this was published last year. And this is from the American Heart Association. It's called the Prevent score. And this is a new score. It doesn't include race, but they have a number of other factors like age, total cholesterol, HDL cholesterol, blood pressure, BMI, EGFR, diabetes, smoking, hypertension medication, and if you're already on lipid-lowering therapy. Importantly, they also wanted to, and we've heard a lot of talks even this morning about looking at social determinants of health. So they also included social deprivation index, which takes into account the socioeconomic status of the place where you live. But with all of these, there still are a number of knowledge gaps. We don't incorporate genetic scores in any of our current risk prediction. We don't have a good way to predict risk of premature heart disease. So that's, will you have a heart attack if you're a male by the age of 55 or if you're a woman by the age of 65? The PREVENT score incorporated some social determinants of health, but it was very preliminary, and we still have a lot of other information that has not been incorporated. And then there's also a new concept now, or an emerging concept about exposure of risk factors. It's one thing to ask, what is your LDL cholesterol now? And how long has your LDL cholesterol been high? Or what is your BMI now? Or how long have you had a high BMI? So the concept of taking duration or exposure risk factors is also emerging, but none of our scores incorporate that. But as we start to think about managing ASCVD risk, once you put a person in a certain category, I think all of us would agree that we can look at risk factors. You may have plaque that's building in the coronary arteries, but it's subclinical, so you haven't had an event. Then you may have a first event. It could be a heart attack or stroke, and then you may be at risk for recurrent events. In all of these, the general approach is to think about identifying patients who are at the highest risk for events. So the goal is to prevent that first event from occurring. And then we'll talk a little bit about looking at some of the non-pharmacologic approaches first, and then the pharmacologic approaches. If we look at the lifestyle changes, the general recommendations are physical activity at least 30 to 40 minutes. And we heard that even this morning, at least 5 days a week. Higher intake of fruits, vegetables, lower intake of high-fat food, which we also heard this morning, lower intake of sweetened food and drinks. But as we start to think about the pharmacologic reduction, this is where a lot of attention has been focused. So I think everyone would agree that they've heard about statins being one of the main therapies that's used to lower LDL cholesterol. There have been a number of clinical trials that have looked at statins for primary prevention. All of them are associated with lowering of LDL cholesterol and lowering of cardiovascular risk. You can start a patient on a high intensity statin if you want to lower the cholesterol by more than 50%. You can put them on a moderate intensity statin to reduce cholesterol by about 30 to 50%, or you can go with a low intensity statin if you want to reduce cholesterol by less than 30%. But a lot of that depends on what the patient's cholesterol is, LDL cholesterol, and what your target is. In addition to statins, a number of other medications have also been looked at. For example, we have bile acid sequestrants. We also have ezetimibe. And these have been mostly used as add-ons to statins. So the patients are already on a statin, and then you add ezetimibe or you add a bile acid sequestrant. There have been little to no studies looking at using ezetimibe on its own or some of the bile acid sequestrants on their own. A lot of them are on the background of a statin. More recently, there have been some other ones which are looking at evolocumab, for example, and that is looking at PCSK9 inhibition. And so these are some of the newer medications that have come, particularly for people who may not be able to tolerate statins, but all of them have, again, have been looked at on the background of a statin medication. And then you have some of the newer ones, and I'm not sure if they're available in the market here, but a few of them are available in the States now. So you have bempedoic acid, you have inclisiran, which is also a new one, which is again PCSK9 inhibition, and those are given less frequently, so they're easier for adherence for patients. So statins is the mainstay, but a lot of physicians and providers tend to hear that patients have statin intolerance. So about 5 to 30% of people may complain or report statin intolerance. And if you want to go by a strict definition, statin intolerance is if the patient cannot tolerate at least 2 statins, one of them being at the lowest approved dose. The most common symptom that patients report is myalgia. It's very rare to have rhabdomyolysis, but myalgia is the most common reason. Given the strong evidence that statins have to lower cardiovascular risk, the recommendation is to try and switch to a different statin, try a different dose. Maybe you can go with a lower dose, or maybe you can change the frequency. Maybe instead of taking a statin every day, they can take it every other day, or they can take it 3 times a week, or they can take it 2 times a week. So try all of these before labeling the patient as statin intolerant and moving to a different medication. And the reason they say this is because most of the medications have not been evaluated independent of statins. They're always on the background of a statin, so we don't know how effective they're going to be to reduce cardiovascular events. One of the main ideas is that if we reduce LDL cholesterol, then we're going to reduce cardiovascular risk, but we haven't seen that for a lot of the newer non-statin agents. So just to look at some of these again, there are cholesterol absorption inhibitors. You can use PCSK9 inhibitors, so alirocumab and evolocumab, or you can use siRNA technology again, which is again going after PCSK9. And then you have fibrate, omega-3 fatty acids, bile acid sequestrants. And then a newer one, and this was published last year as they completed a clinical trial where they looked at bempedoic acid and then also looking at pemafibrate. And pemafibrate is a very good example of that. It can change your triglyceride profile, it can change your LDL cholesterol, but it doesn't necessarily reduce your vascular events. So that's why they want you to focus on medications that actually reduce cardiovascular events. One of the questions that has come up a lot is, how low should we go with LDL cholesterol? Is it good enough if they're just on a statin, or how low should what should our target be? The European guidelines recommend LDL cholesterol of less than 55, and if a person has had more than one event, to aim for less than 40. There have been a few studies which have said that very low LDL cholesterol is associated with a higher risk of hemorrhagic stroke. So some people have been concerned, and they said maybe if we reduce the cholesterol too much, then they may be at risk of hemorrhagic stroke. But this was not seen in the clinical trial data. So in the Fourier clinical trial, in some patients, they reduced the cholesterol to under 25 milligrams per deciliter, but there was no difference in risk of hemorrhagic stroke. Same one in IMPROVE-IT clinical trial. They looked at statin plus ezetimibe. They reduced some people's cholesterol to under 30 milligrams per deciliter, but they had the same safety profile and there was no high risk of hemorrhagic stroke. So overall, looking at everything that we have for LDL cholesterol, looking at statins and non-statin agents, most of the literature says that LDL is a key contributor to ASCVD risk. LDL cholesterol reduction is associated with lower risk. Lifestyle change can contribute to lower risk, and that statins are the main therapy to reduce LDL cholesterol and ASCVD risk. In some individuals who are statin intolerant, you can try non-statin agents, but you want to be careful. You want to try all your statins first and then consider a non-statin agent, particularly because we don't have strong evidence for non-statin agents as the only medication to reduce cholesterol. So with that, I'm happy to stop here and then looking forward to the discussion later. Thank you.